Welcome to Bullet Point Nursing. In this video, we're going to go through seizure medications for the advanced pharmacology course for nurse practitioners. Let's go ahead and start with a little bit of background so that we understand when we're prescribing medications if we're talking about an active seizure versus chronic seizure disorder known as epilepsy. First, let's begin with active seizures. Most seizures, and we talk about seizures for right now, we're talking about the generalized tonic-clonic, the jerking motion that we all associate with as being a seizure. Most seizures do resolve on their own. In fact, the vast majority of seizures happen outside the hospital, and the seizure has resolved before the patient ever gets to the hospital. Most of them resolve in under 2 minutes on their own. That being said, if we do have a patient of ours that we're caring for as a nurse practitioner that is having an active seizure, we are going to go ahead and almost always administer that benzodiazepine. First and foremost, just like we have in cardiac, where we look for the H's and T's, those reversible causes of, let's say, cardiac arrest, it's going to be the same thing with seizures. We have to look for the underlying cause that's going to be fundamental in taking care of a patient who's having a seizure. Those underlying causes can be electrolyte imbalances, such as a low sodium. It could be certain toxins. It could be withdrawal, let's say, from alcohol, certain infections, trauma, stroke, tumor, fever. All of these can cause seizures. All of these must be investigated in order to determine the underlying cause of the patient's seizure. Remember, if we don't find an underlying cause, and this is happening regularly, that's when the patient gets diagnosed with epilepsy, and we'll talk about that in just a minute. For charting purposes, for management purposes, you do need to know what type of seizure it is. So remember, just brush up on if you're not familiar. Focal seizures where it's not affecting the entire body, let's say a certain limb or something like that. Generalized seizure is what we classically associate with as the generalized tonic-clonic seizure, where the full body is doing the seizure motions, and an absent seizure is what the brain is having a seizure, but there's no movement associated with it. There might be outward physical symptoms, such as the patient is not fully alert, but the patient is not having that classic motion that we associate with the seizure. The first line medication that we're going to use for seizure management are going to be benzodiazepines. We're going to talk in just a few minutes when we get there which specific drug we're going to want to use, but benzodiazepines are going to be our first line. If we give a patient a benzodiazepine for their active seizure, and again, let's go back to that generalized tonic-clonic seizure. If we give a patient that benzodiazepine and they're still not responding to it, meaning the patient's still having a seizure, then at some point, usually around the 5-minute mark, we are going to go ahead and move on to our second line drugs. These are almost all going to be IV infusions. And this is going to be fosphenytoin, valproic acid, levetiracetam, or phenobarbital. These medications would be second line for a patient who's still having a seizure despite having already gotten benzodiazepine. We may also use this for patients that are having repetitive seizures, not necessarily that it didn't stop, but that their post-ictal phase just leads right into the next seizure, right into the next seizure. It doesn't literally have to be that the patient was seizing nonstop. Status epilepticus is where a patient is seizing nonstop, although I have seen some textbooks that include status as where the patient, again, like I just said, is having a seizure, goes post-ictal, but never fully recovers before they get right into the next seizure. But generally, most textbooks consider status where the patient's just seizing nonstop. In that case, and the time frame for that, depending on your textbook, I've seen as low as 5 minutes, as high as 20 minutes in my research. So somewhere in that range is where we diagnose them with status. In this case, patients will generally need intubation. Keep in mind when the patient's having a full generalized tonic-clonic seizure, every muscle in the body is spasming. The diaphragm is one of those. So since it's spasming, it's not properly ventilating, the patient's going to need to get intubated. Patient may also need paralytics because the body can run a very high risk of overheating and causing secondary damage if we allow that patient to continue having this very high intensity motion of a seizure. Next, let's look at epilepsy. Epilepsy is chronic seizure disorder. It's officially diagnosed when a patient has 2 or more seizures more than 24 hours apart without an underlying cause. If we have an underlying cause, then that wouldn't be epilepsy. That would be whatever the underlying cause is. It would be, let's say, seizure secondary to hyponatremia. Next, now let's start talking about prescribing medications. First of all, in the case of a patient who has epilepsy, these medications are going to be long-term. I put lifelong. They may not always be, but they're definitely going to be long-term medication. It's not going to be, I take it for 6 months and I'm done. In kids, if let's say they are diagnosed with epilepsy, we might be a little bit quicker to get them out of it, maybe 2+ years. But in adults, it's generally going to be, most guidelines say 2 to 5 to 20+ years before we even think about getting them off the medication. Now, when we ever do try to get a patient off the medication, and generally, by the way, we have to have a good reason. There's really no reason if a patient's, let's say, had seizure disorder and was having 3 seizures a month, and we started on them on Keppra, and now they have no more seizures. and it's 15 years later, generally we're still going to let them just continue on that medication unless we have a reason to take them off. Let's say now they have a heart issue and they're going to be on other medications that interact, something like that. But generally, there's not a good reason to take a patient off medication when it's working successfully. If we are going to be doing that, we are going to have to taper the medication off. Seizures specifically, and this is why I just said that a minute ago, seizures specifically have a very high risk that as soon as we stop the medication, they develop a seizure again. Remember, our goal in treatment, not remember, I haven't said it yet, but our goal in treatment is to increase the seizure threshold. What does that mean? That means we want to make it harder for the body to develop a seizure. We want to make that threshold, that level that where the body hits a seizure, we want to move that level up and up and up so that it's harder to hit that so that the patient doesn't end up having a seizure. Now, with that, we have to understand that when we stop taking the medication, that seizure threshold is going to come down, which reintroduces that risk of developing a seizure. When we are starting a patient on seizure medications, we're always going to start with monotherapy, just one medication. And then if that doesn't work, then we go ahead and move on to combo therapy. Pretty much, I don't deal with that specifically, but pretty much that's always going to be done by the neurologist because it would be pretty odd for someone outside of neurology to start messing around with multiple seizure medications. When a patient is diagnosed with seizure and when they're placed on seizure medication, this is an important test question. Make sure you're educating the patient on avoiding any seizure triggers. The famous one is the flashing lights. That's a common test question, but there's lots of other ones. Smoking can be one, or secondhand smoke. Stress can be one, fatigue. So lots of different seizure triggers. We also want to educate the patient on medication compliance. Again, they're seizure-free because of the medication. Hopefully they're seizure-free, but they can't get comfortable with that if they stop taking the medication. If they stop being stringent with taking it, they can't right away again go develop a seizure. When we are treating a patient with seizure disorder and they're on one of these chronic long-term medications, we're generally going to have to monitor the patient very closely. That means regular labs every 6 months or so, depending on the drug, and depending, obviously, when we're first starting it much more frequently. We want to make sure that the drug remains within the therapeutic range. We want to monitor to make sure that the patient is meeting our goal of being seizure-free or as close to it as possible. We also want to monitor for side effects. Side effects is a big testing point in advanced pharmacology, so make sure you're watching out. If a test question says something about a patient develops a rash, do they need to immediately report that? Well, if it's one of the drugs that has the risk of developing Stevens-Johnson syndrome, then absolutely they need to immediately report that. When you're prescribing a patient a long-term medication for epilepsy, keep in mind that there are going to be some major quality of life issues that you have to educate the patient about, and you may have to provide them supportive resources. For example, in, I believe, every single state in the United States, if a patient is newly diagnosed with epilepsy, they lose their driving privileges, they lose their driver's license. So that's a major quality of life issue, how they can get to work, how they can get their kids to school, things like that. Depending on the state, I believe it's somewhere around 3 months to 2 years before a patient can get their driver's license again, meaning they have to be seizure-free for roughly 3 months to 2 years, again, depending on your state. Water activities, you must educate patients if they have seizure disorders. There's no swimming in the ocean without someone right there with them. There's no swimming in general without someone supervising, because if a patient does have that seizure disorder, they may, and they develop a seizure in the water, they can very quickly die and no one will know about it. Finally, let's talk about pregnancy. This will come up as we go through the drugs, but I want to make 2 points really crystal clear right from the beginning. Number one is a bunch of these medications are not going to be recommended in pregnancy. However, valproic acid is universally considered the worst one in pregnancy. So we're going to talk in a few minutes that when a patient is on a medication for epilepsy, if they become pregnant, generally, unless it's valproic acid, we still want to keep them on their medication. I really don't want to change a patient's seizure medication, especially if they've been on it long term and it's been successfully working. I really don't want to change their seizure medication. So generally, we're going to keep the patient on whatever they're on. Valproic acid is one exception because this is highly teratogenic. For this reason, we also try to use this as a last resort option for females of childbearing age, because if they do become pregnant, we're sort of going to have to get them off this seizure medication, and that can be a problem because, like I just said, we don't want to do that. That being said, even if a patient is on a not desirable seizure medication, again, valproic being the exception, if they're on a not desirable seizure medication, very often we're still going to keep them on it because the risk of developing a seizure is extremely high. Now, if they've been easy to manage and we think we can easily get them to different medication, then we'll go for it. But generally, we may keep them on the medication because the risk of mom having a seizure is extremely bad for baby, equivalent to, if not worse, and I'm not saying this with any authority here, but it's almost as bad or somewhere in the same ballpark as bad as the medication itself, even being teratogenic. Again, for test purposes, valproic acid is a no-go in pregnancy. Other than that, if a patient is a female childbearing age and going to be on any of the seizure medications that are not great in pregnancy, then we are going to recommend the patient take folic acid. Folic acid supports pregnancy, so we're going to recommend that sort of to offset the minor risk that's involved with most of the other seizure medications other than valproic acid. Let's go ahead and start with benzodiazepines. Benzodiazepines are going to be our go-to drug for active tonic-clonic seizures. This is not recommended for long-term seizure management. Make sure you know that. Even though it can do that, it is not recommended for that. The first line drug is going to be lorazepam. That's Ativan. That's going to be our go-to for any patient that's having an active seizure. Some protocols will have midazolam or diazepam. Some will have those as a second, some as a third. I don't have a specific order for which one would be second or third line out of Versed and Valium. But those two would be the next best options for patients actively seizing right now. But lorazepam for test purposes can be your first one go-to. Next, how does this work? These are GABA agonists. GABA is an inhibitory neurotransmitter. It slows down activity in the brain, which is exactly what we want when the brain is firing uncontrollably during a seizure. That's how that works. The indications for this is a very long list of indications. This is a seizure video, so I'm going to try to keep it focused on seizures, but we use benzos not only for seizures, but for anxiety, for sedation, as a muscle relaxant. We use it for alcohol withdrawal. We use it for a bunch of different things. It does have a number of side effects. And for all these side effects, these are just for test purposes, things that you would have to monitor for, but things that you would expect. You expect the patient to develop sedation. Amnesia would be most common in midazolam, so that wouldn't be an uncommon effect with midazolam. If you see that on a test, that's normal. CNS effects, mostly that relates to sedation. Respiratory depression, hypotension are two more issues. So if a patient is hypotensive, or having already a low respiratory rate and you go ahead and give them benzo, please make sure you're ready to give them fluids to treat that hypotension or to intubate if necessary to address those effects. Caution in giving these medications to elderly. This is in general, it increases their fall risk. That's a common nursing level test question. In pregnancy, this is kind of debatable whether you can give this in pregnancy or not. We know that the longer seizure goes on, it's extremely detrimental to pregnant mom and to the fetus. So we want to make sure and terminate that seizure as quick as possible. But we also want to consider the fact that it's not great in pregnancy. In a patient who's having an acute seizure, I can't help you because I've literally seen some textbooks that say benzos are contraindicated and some guidelines that say that you should go ahead and give it because seizing is worse. I'm going to stay out of that and just give you the information. Finally, long-term use. We've already mentioned this earlier. Benzos can be used long-term for seizure management, but they should not be. We have much better, much safer, more effective drugs than benzodiazepine. The big risk there is that they're going to develop tolerance and they're going to need more and more of that medication. Can't move on without reminding you from RN level that benzodiazepines do have a reversal agent. It's called flumazenol, and it can be given to reverse the effects of a benzo. Keep in mind, if you give it, you are risking seizures, so never give it in a patient that has seizure disorder because if you give this medication, your future doses of benzos until the flumazenol wears off are going to be ineffective. And now the patient develops a seizure, you have no medication to treat it with. And finally, just a reminder, benzos are a controlled substance. I believe they're a class 3. Next, we move on to phenytoin, which is dilantin, or fosphenytoin, which is Cerebrex. So these medications, the way they work is they are considered hydantoins, that's the drug class, and they stabilize sodium channels. You're going to see this mechanism of action on a few of the drugs that we go through. They stabilize sodium channels, which helps reduce seizure activity, and it helps increase the seizure threshold. Fosphenytoin is an IV infusion medication that's used specifically for status epilepticus. When it is given, it does have a black box warning that it must be given by slow IV push. That's fosphenytoin. Phenytoin is an oral medication that's taken for long-term seizure management. These medications are generally contraindicated in pregnancy. Again, this isn't super teratogenic like valproic acid. This is definitely be one where if we decide to continue the patient on this as they're pregnant, we're going to go ahead and supplement them with folic acid. But again, per the textbook, this is contraindicated in pregnancy. Though again, I have some guidelines that said keep them on it, monitor, and give folic acid. Those are also talking specifically where we've tried other medications like levetiracetam and lamotrigine that we'll get to in just a minute, and those were ineffective. These medications, phenytoin and fosphenytoin, they do reduce the effectiveness of oral birth control. So if a patient is a female childbearing age and they are going to be on this medication, then we should also, and they're already taking birth control or they're asking about birth control, keep in mind this standard hormonal contraceptive pill is not going to be as effective in this patient because of CYP450. The way that works, the way the birth control works, and the way this medication works, it's going to reduce the efficacy. So you must educate patient. It's a fair test question. You must educate the patient who's a female childbearing age taking phenytoin to use another method of contraception in addition to oral contraceptives, or just replace the oral contraceptives. The drug level of phenytoin is 10 to 20 micrograms per milliliter. That is a fair test question at the APRN level. An early sign of toxicity is nystagmus. And a big thing to know for test purposes is that this drug can be cardiodepressive, meaning low heart rate, low blood pressure can suppress the cardiovascular system. That's a big thing to know about with this drug. So be very mindful that you have your nursing orders to monitor this patient very closely, specifically their vitals and their cardiac activity. Again, this medication is available oral, that's the phenytoin, IV infusion, that's the fosphenytoin. Next, we have valproic acid. We mentioned already earlier, this is the absolute teratogenic one, nothing to talk about. We can't use this in pregnancy unless there's no other choice, in which case we're taking very major risk with the baby. This is considered a broad spectrum anti-seizure medication. We use this for seizures. It's also used for bipolar disorder, migraine prophylaxis. I probably should have mentioned this at the beginning of the video. You'll notice a bunch of these drugs. I'm only talking today about seizures, but a bunch of these drugs, since they're all neurology medications, they're going to work for a lot of different things, such as bipolar, such as migraine prophylaxis, such as neuropathic pain. But a lot of your seizure medications are going to also work for other things like that. The mechanism of how these work, valproic acid has a bunch of different ways that it works, but it actually combines the last two effects that we just saw from the benzos and the phenytoin. It both increases the GABA effects and it stabilizes sodium channels. Again, this is contraindicated in pregnancy. This actually has 3 black box warnings that it's hepatotoxic, so do not prescribe this without checking their baseline AST, ALT. It is teratogenic, so do not prescribe this without checking a HCG, a pregnancy test, on females of childbearing age. And it has a black box warning for pancreatitis that it can cause pancreatitis. So if they have a history of pancreatitis, do not use this medication. If the patient is on this medication, make sure we are monitoring their liver function test. We're going to monitor their CBC because this can cause thrombocytopenia or other blood issues. And we're also going to monitor their valproate level. Their valproate level should be at 50 to 100 micrograms per milliliter. Moving on, we have levetiracetam. This is Keppra. This is one of the most popular medications today for long-term seizure management. This is also one of the most popular medications for status, where a patient is having, they already got the benzo, still having a seizure, and we're moving on to an IV infusion. That's where we might use levetiracetam. This is available both oral and IV. This is a broad spectrum IV agent. This is one of the best agents to use, and this is a good test question. This is one of the best agents to use for a female childbearing age because this is one of the safest in pregnancy. We use this for both partial and generalized seizures, as well, like I said, as status epilepticus. How this works, you shouldn't be tested on it because we don't exactly know how this works. We know that it binds to SV2A and it modulates neurotransmitter release. Even if that doesn't make sense to you, that's fine, because we really shouldn't be testing on this because officially we don't know exactly how this medication works. It does have minimal drug interactions. It is considered the best option in pregnancy, so it has a lot of advantages because of that. It is very commonly used. However, we do still have to be monitoring the patient very closely to make sure the medication is working, to make sure they're not developing any adverse effects, and to make sure the medication is not becoming at a toxic level. But generally speaking, that's one of our preferred agents. Now let's quickly go through a bunch of the other agents. I'm not going to go as deep into these, but still I want to include them so that you're well prepared for your seizure exam. Ethosuximide, this is a medication, the drug class is succinimide. This is another one we're not 100% sure exactly how it works. We use it specifically for absence seizures. That's where the patient is not having the outward jerking motion, but we're in the brain, they are having that seizure activity, and the patient is not fully conscious at that time. We do use this only for absent seizures and nothing else. Topiramate, which is Topamax, is another anti-seizure agent. This is a broad spectrum agent. It's very interesting as I'm going through the research because some textbooks, and I have all of them, some textbooks say that this medication is a preferred agent, and some say to avoid it because it has a bunch of secondary issues that can happen with this medication. I'm staying out of it, just giving you the information. We do use this for seizures. We use it for migraine prevention. It is associated with weight loss. So that is something that we sometimes want to use it for. We can also use it for bipolar and certain other disorders, but this is the main one. Again, we're talking only seizures today. The side effects of this one, the biggest one, is this is where patients complain of that classic, I feel like my brain is foggy. They have cognitive slowing. They're not 100% functioning mental capacity wise. So that's a major side effect that we have with topiramate. That's a big reason why a lot of providers, prescribers do not like using this medication. Generally, when we are using this medication, we've already tried other medications. It's pretty uncommon for this to be used as a first-line drug, with the exception being if we're trying to get that weight loss effect. Then we may move this up higher on the list and say, let's go ahead and use it. This is also completely unrelated to today, but this is also part of a two-drug combo for weight loss, which is phentermine and topiramate. Next, more other secondary third-line drugs. We have carbamazepine. This is not a broad spectrum. This one is used specifically for focal seizures for our seizure discussion. It's also used for trigeminal neuralgia and bipolar disorder. In this patient, you do need to closely monitor their CBC, their liver, their sodium specifically, but let's just say all electrolytes for test purposes. And their therapeutic level should be at 4 to 12 micrograms per milliliter. And if you see it going above that, then they're becoming toxic. Both this drug and the next drug have the risk for developing Stevens-Johnson syndrome, which is, again, that major adverse dermatological condition. So you definitely want to pay attention on a test if it says which of the following should the patient immediately report, even though rash usually sounds pretty innocuous. In this case, it's definitely something that they have to report right away. Lamotrigine is, before I skip that, interactions, it does have that CYP450 interaction. Anytime you see that in seizure world, that means that this medication is going to reduce the efficacy of your birth control. So you have to educate the patient to use other means of contraception. Also, it's going to mean any of the CYP450, warfarin, and lots of other drugs. It's definitely going to interact with those. If a patient does have other comorbidities and they're on other drugs, this would not be a great choice. Lamotrigine, this is a broad spectrum antibiotic, anti-seizure medication. This is known as Lamictal. And this medication is also another one that is more and more being used for seizures as a go-to drug. It does have minimal interaction, so we do like it, kind of like levetiracetam. A lot of people get these two confused because levetiracetam and lamotrigine, Lamictal, and Keppra are two of the most preferred agents nowadays, and those two are the two best ones for pregnancy, by the way. So if the patient is a female childbearing age, especially if they're still planning or trying to become pregnant, we're almost always going to go to one of those two, levetiracetam or lamotrigine, as our go-to drug for their first-line seizure management. This does have the same issue with the caution for a rash with Stevens-Johnson syndrome or toxic epidermal necrolysis. Last two we have are phenobarbital and lacosamide. Phenobarbital, this is a barbiturate. This works similar to benzodiazepine in that it increases the effects of GABA, so it slows down activity in the brain. Specifically the excitatory activity, regular activity is just fine. The therapeutic level for this should be at 10 to 40 units per ml. This medication does have a very high risk of addiction, which is why this is not counted as a first-line agent anymore. This would not be your go-to drug. This does have major risks of respiratory depression, hypotension, and sedation. So if you do give this to a patient, just plan that you're going to end up having to intubate them and possibly address hypotension as well. This medication should be avoided in pregnancy. Again, this goes back to everything we said about pregnancy, that if this is the only drug that's working, which if they're on it, it probably is the only drug that's working because this isn't first line, then we may have them continue on it and supplement with that folic acid. This is also CYP450 issue. So that means it's going to reduce the oral contraceptive efficacy. Again, that's a big test question. That's why I keep saying it. So you're going to educate the patient to seek another method of contraception. Finally, we have the lacosamide. This is a narrow spectrum. It's used for focal seizures. This one also works by stabilizing sodium channels like we've seen earlier. The big test question, actually the only test question I really found about this one, is that it prolongs PR interval. So definitely don't use this in a patient that has underlying cardiac issues, and definitely monitor the patient's cardiac activity with this drug. Hopefully this helps you for your class. If you have any questions, please reach out. Otherwise, have a great day and see you in the next video.